Good evening, everybody. I am Dr. Satish Rao. I'm professor of medicine and a neurogastroenterologist at Augusta University, Medical College of Georgia, Augusta, Georgia. And I have two wonderful friends and colleagues here to join me in this, what I hope will be a roundtable discussion on irritable bowel syndrome and its various facets of this disorder. So on my right, I have Andrea. So Andrea, can you tell us about yourself, please?
Yeah, no, I'm excited to be here. My name's Andrea Shin. I'm a gastroenterologist at UCLA, and I have an interest in irritable bowel syndrome, and so do a lot of clinical research in that area too.
Welcome, Andrea. And to my left is Ali Rezaie.
Thanks for having me. I'm Ali Rezaie. I'm the director of GI Motility program at Cedars-Sinai from Los Angeles as well. And I also interested in doing a lot of microbiome research, mostly related to gut health, but other indications as well. Thanks for having me.
Thank you, Ali. And that's a great intro. So that takes us, first of all, what I wanted to ask each of you is, where are we with the IBS treatment landscape today? So let me start with you, Andrea, and can you tell us a little bit about your management plan when you come across a patient with, let's say, irritable bowel syndrome with constipation predominant symptoms? How do you approach them? How do you manage them? And any suggestions, recommendations from any national guidelines, etc.? So can you share with us?
Yeah, no, I think, over the last decade or so, there's been just a really growth in the landscape of treatment options. And obviously we have different treatments for irritable bowel syndrome with constipation compared to diarrhea. I think for me, if I have a person or a patient who comes in with constipation symptoms, obviously we try to really understand what their symptom pattern is like. You might really dig into how they describe their constipation. Some people with irritable bowel syndrome and constipation can also have rectal evacuation disorders. So I always try to elicit that, in our conversations during the visit. And if those are, if that's a feature, or that's part of the picture that I'm worried about, then we can offer them physiologic testing to really follow up on that. And the great thing is that if we can identify that early on, there are treatments that we can implement, like, biofeedback or pelvic floor physical therapy. And then after that, depending on the patient as well, there are a bunch of pharmacotherapies we can use. And so those are things that I'll think about. And obviously the treatment plan might differ for one person versus the other, but we try to tailor it depending on.
So, generally I find that the guidelines quite often start with something like fiber supplements, education, dietary recommendations. Do you use any of them as your first line approach?
I think all of those aspects of the guidelines are really valid. But, most of the time by the time patients come to see us, they've already tried a lot of that. But obviously, covering that and making sure that has been implemented adequately, making sure, fiber has been tried, or have they identified, different dietary behaviors or potentially regimens that might exacerbate symptoms. There is some role for that as well. But usually that's kind of complementary to the approach, but rarely, when I have an IBS patient, it's rarely the sole treatment.
What about prescription treatment? So what are your top 3 prescriptions that you use for your management, and any reason why you pick one or the other?
I think a lot of patients with IBS-C now, because there are multiple approved therapies, the options are, they're pretty wide ranging. I probably start more commonly these days if I am using like an FDA-approved prescription for IBS-C. I think I'm more commonly using linaclotide at the outset. Again, because we're more of a referral-based practice, most patients have already tried things like, osmotic laxatives or standard over-the-counter treatments. So the reason I'll often use linaclotide is that some of the studies have suggested that it potentially may be the most effective in not direct head-to-head trials.
But you probably have the most experience with that too, maybe because it's the longest.
It's been around the longest. There's the more data on it, but it may not be the right treatment for everyone. So you might start with one of those treatments and then potentially move on to a different therapy if that either isn't effective or maybe side effects are other things that we have to consider.
So Ali, along the same theme, what about the other FDA-approved drugs? I guess, right, there is lubiprostone that's been approved, tenapanor, placanatide. So what are your thoughts? How do you use them in IBS management?
One point that Andrea was making is that by the time that patients come to us, they have tried some. So that's one factor. What have they tried and what have they failed, right? So that's one thing. But the other factor that always gets missed in the clinical guidelines is that, okay, what insurance covers what? That's the reality of our lives, right? So that's very important, what you reach for. For example, I'm just going to be candid about that. If we have a patient with no supplementary drug coverage, if I'm going to go for a medication, probably I will go for generic lubiprostone, right? Because that's going to be the cheapest prescription medication that I can reach for, right? So that's one option. Having said that, it may not be my first choice if patients' insurance would cover another drug, because we all know that we have issues with lubiprostone, especially with nausea, right?
Right.
And the dose of the drug that is available is a little bit odd. It jumps from 8 to 24, and it's really hard to adjust the dose a little bit. So that's one main factor that plays a role in my clinical practice. But nevertheless, I do use Trulance, which is placanatide. I do use Ibsrela, which is tenapanor. I do use... I know it's not approved in IBS constipation, rather approved in chronic idiopathic constipation, but I do use Vibrant, even standalone or a combination. And I think one thing that it's worthwhile to talk is that even though it's not in the guidelines, every now and then, every one of us uses combination therapy, and that's one thing that we may need to discuss.
Right. I think that's another point. So let's say you're trying your prescription treatments and your patient comes back and is still concerned that bowels are better, but there's still a lot of pain, etc. So what would you do then in your approach?
Yeah, that can be a really common scenario, that we've treated their constipation or we've helped them better improve their bowel functions, but they're still struggling with pain. Usually in that case, I will think about adding something like a gut-brain neuromodulator to help them with the pain symptoms, and understanding that may or may not have a direct impact on their bowel functions as well. But there is a good amount of data now suggesting that central neuromodulators like TC.
So are you looking more at tricyclics, SSRIs, SNRIs? Do you have any thoughts on one or the other?
There's probably more data to support the role of tricyclics in irritable bowel syndrome, although I do also use SNRIs as well. SSRIs, I may not use to directly treat gut symptoms, but if it's someone who also struggles with coexisting anxiety and they report that the anxiety can make their GI symptoms worse, then, I might reach for an SSRI in that case. So the neuromodulator that I choose really depends on the person.
And so Ali, let's say you've tried these approaches that we've explored so far. Patient still is back. Clearly, let's say an IBS patient with some trauma in the past and so on and so forth, and it was not forthcoming, at least in the first 2-3 visits. You managed them, and they've got some symptomatic relief. They still have a lot of faith in you. They're back in your clinic. What else would you do to help such a patient, still having pain and still having some bowel issues and constipation area?
Yeah, so especially if you're talking about psychological traumas, I generally refer those patients to a GI psychologist if that's one issue that can be addressed over there, and I ask for their help. And again, whenever a patient comes back to my clinic and symptoms are not perfectly controlled, there's some improvement maybe in some areas and there's some remnant symptoms, I will step back, say that, okay, am I missing something? What's going on? I mean, that can be something in the history, as you said, in trauma. That can be something on the examination. Am I missing, as Andrea was saying, a pelvic floor dysfunction? Am I missing whatever? It's a small intestinal bacterial overgrowth or EMO. Am I missing? Is this a case of endometriosis? Let's step back. Okay, am I missing something like that? Right. So I always step back.
And that's very important. I mean, many physicians don't do that, right? I think they always need to really step back for a second and revisit the history and the exam, and are you missing something that's not obviously glaring at you?
Yeah, absolutely. And I think redoing almost the history and doing a directed physical examination, sometimes, first of all, it gets the attention of the patient and brings more trust of a patient that is a returning patient. And I think that helps a lot. And that potentially will help.
What about any of these cognitive behavioral therapies and the apps and so on? Do you use any of them? Do they have a place?
I just refer them to GI psychologists.
So you let them...
you let them drive that.
Drive the whole thing.
Drive that.
I think that was a very good discussion on IBS constipation. Let me turn to you, Ali, and lead the discussion a little bit on the IBS diarrhea front. So after our standard approaches with fiber, etc., what else would we do then next in your management? Now you have a patient who's got more diarrhea, predominant pain, IBS symptoms.
Right. So in IBS diarrhea, as Andrea was saying, we have essentially 3 approved drugs. So we have less approved drugs there. One of them is barely available, i.e. Locitron or Lotronex, right? So loxadilline and rifaximin are the other 2. But the good thing about IBS diarrhea, there are a lot of tricks available, whether within the guidelines or not, that can help the patient. I have to say, for example, I do use very commonly 5-HT3 antagonists. The good old Zofran and Lancetron is one thing that I commonly use in these patients to help them. But if I want to reach for prescription medications, I try rifaximin. That's one treatment. And if patient responds, obviously that's a different category. But if patient does not respond, obviously loxadilline is available. So those are the approaches that I take. But again, IBS diarrhea is the same story. I step back and make sure that I'm not missing anything every time that patient fails a medication. So that's very important. Revisiting if you're not missing anything, that's very important.
That was superb discussion.
Yeah.
So I think we've covered, very nicely the current treatment landscape. As academicians and as people listening to this podcast, they're always interested in what else is coming down the pipeline. What does the future landscape of this field looks like? And there were a few products that we were able to cull together. And so I wanted to just have a very quick, brief discussion and see if you have any thoughts. Let me start with you, Ali, and ask you about this fructosil-lactose, which was brought up in a discussion recently.
Yeah, absolutely. There is no question that microbiome has a role in irritable bowel syndrome, and definitely a subpopulation of IBS patients when we adjust or balance, if you will, the microbiome, they symptomatically improve. So definitely microbiome-directed therapies need to be continued in the field of IBS. And one of them is the one that we discussed, which is a prebiotic derived from milk. And there was some encouraging data in the past, but there's some ongoing studies to see if this works, and also some encouraging data in IBD, considering that this probiotic leads to increment of butyrate in the colon. Definitely, I mean the role there is a role there. Having said that, the problem with prebiotics, in my opinion, is that eventually every patient will respond to these treatments based on their native microbiome, right? So the way my prebiotics will work in me is not going to be the same as the other patient. So we need some sort of differentiating microbiome signature to see who will benefit from this patient, right? From this treatment, because otherwise it's going to be the same as all other therapies. I think we need to find how to do precision medicine in IBS if you're going targeting microbiome specifically, because one treatment is not going to work on everybody, so we have to fix it, right?
So talking about microbiome and precision medicine, Andrea, I think there was this late-breaking abstract that was presented at DDW. I don't know whether you either heard or learned about that, by this company coming out of England. They have a product, I think, Enterobiotics. It's claimed to be a full spectrum microbiome encapsulated. And I think in the clinical trial, they took 2 doses a week apart of 8 capsules, and they did a randomized controlled trial against placebo, 2:1, in about 120 patients, 60 IBS constipation and IBS diarrhea kind of stool. So what is your thoughts both on the clinical trial and their outcomes, and what do you think of this kind of an approach for IBS management? I ask you because particularly you have a lot of interest in microbiome, and that's your research and so on too.
So I think, conceptually that this treatment sounds very similar almost to the fecal microbiota transplant, but it's a defined consortia. And it seems more of like a broad-based treatment, like you're identifying a group of microbes that we feel are just healthy in general and then kind of implementing it in a non-selective fashion. But just like Ali was saying, is that the microbial perturbations are probably variable across people with irritable bowel syndrome. There's probably a lot of heterogeneity in there. So it sounds like, my take on that is, okay, we're possibly trying to augment a healthy community, but it may or may not be what's missing in that person. So it's still, I think it's very interesting, and it's still pretty early, but eventually the idea of kind of being able to personalize our approach is going to be really important. But yeah, that was kind of my impression of it. I think
so I think so both of you are saying the same thing in very nice way, that somehow if I think you can put 10 different what you conceive to be a very healthy microbiome in a capsule, but are they those 10 that are either missing or dysfunctional in a particular individual with IBS symptoms? And if not, replenishing them may not have a big impact. Whereas if it happens to be, then that could have a significant impact in their symptoms. I think that's...
No, I absolutely 100% agree. I think Andrea brought up FMT, and if you look at all the clinical trials done in FMT and IBS, they're rather disappointing. That's the reality of it. And it appears that, this is my opinion, that additive approaches in IBS are not a blockbuster, let's say, right? FMT has failed. Probiotics are all over the place type of thing in terms of response, and prebiotics have been a little bit tricky to interpret. On the other hand, reductive approaches have been more successful. Rifaximin is a good example, right? So there are two school of thoughts. Should we take something that is doing bad things, or do we just dump a whole bunch of good things and see if they do the job, hopefully, right?
Right.
And a reductive approach is more amenable for precision medicine, in my opinion, as opposed to additive effects.
Yeah, I think there was another compound, this
Yeah.
OPS 2071, which is a fluoroquinolone, which is minimally absorbed, not as much as the standard Cipro or any of those drugs, and that is also under some early clinical trials. Are you familiar with that?
I was not familiar with that trial, but yeah, we had a discussion about that earlier. But that is an interesting, alternative.
Yeah, it's about the same lines that you're talking about. Right. I wanted to almost close this discussion, but maybe just touch on a couple of compounds. One is crofelemer, which you are a little bit more familiar with. So give us a quick 1 minute synopsis on what you think of its role.
Crofelemer is actually a very interesting compound. It's one of the few botanical compounds that is FDA approved, right? It's derived from a tree in Amazon, it's called dragon sap. And what it is approved right now is for HIV-associated treatment, diarrhea. So what this medication does is that it decreases the secretion of fluid inside the gut by blocking the chloride channels, right? Think of it as a reverse lubiprostone type of medication. So this is very promising in the setting of helping with diarrhea, but the clinical trials have been a little bit mixed in results, right? And another thing is that the effect on pain obviously is not as prominent, but definitely worthwhile to find that subgroup of patients that again respond to these compounds.
So let's, Andrea, let's have a brief few-minute discussion on the comorbidities that surround IBS. I mean, of course, we as gastroenterologists primarily look upon this as a GI, gut-brain interactive disorder and so on, and we manage those fairly effectively. But then these folks have a number of comorbidities. Can you tell us a few that you've seen and you think are important, and how can we go about really recognizing them clinically?
Yeah, no, absolutely. Comorbidities are really common for people with irritable bowel syndrome. It's been well documented that people with IBS can commonly suffer from coexisting anxiety or depression. But there are also other comorbidities that are not necessarily psychological. So if you have IBS, you're much more likely to have another disorder of gut-brain interaction like functional dyspepsia. So it's common to have more than one DGBI. And then in addition to that, people with DGBIs or irritable bowel syndrome often have what we call like non-intestinal comorbidities. So pelvic pain, chronic pelvic pain, fibromyalgia, migraines, other types of comorbidities that may not necessarily fall under the same disease category, but could share common mechanisms in terms of pain pathogenesis. That's also a pretty common feature that we see.
Yeah, interstitial cystitis is one more, right? Yes. That is very common in people that we tend to. And so recognizing them, and how often do you see them in your practice? Do you think a good proportion, a third of your patients have this?
Yeah, my practice is probably enriched for people who have comorbidities. So I would say, the majority of patients with IBS have at least one comorbidity when they come in. But in the published data, even if you look just in more kind of general cohorts, people with irritable bowel syndrome, like a third of them will have another DGBI. So again, it's very common.
So recognizing that it is as common as Andrea just said, Ali, how do you really manage these people? I mean, do you have any special tools up your sleeve that you use to approach and manage these people?
I don't want to harp on the same thing over and over again, but it all comes back again to, for each individual patient, is an individual approach, right? Yes, as Andrew was saying, that each one of those that you find a comorbidity, there is specific medication sometimes that works better in that scenario, so and you approach that, right? I mean, other comorbidities, one group of cases that we are seeing more and more are patients with POTS, for example, right? So if I have somebody with that group of symptoms, obviously I ask help from our cardiologist with that expertise to see what they want to do. If, for example, patient is constipated and not responding to usual ones, that's a scenario that I reach for pyridostigmine, for example. Why? Because there's a clinical trial on that field that was positive, small, but positive, right? So the point I'm making is that there are some specific treatments for all those comorbidities that potentially that treatment can have a positive effect on the IBS too. So I always think about it the other way around. Okay, this patient has this disorder, so can I treat that? Maybe IBS gets better, rather than let's try everything on IBS and see that one gets better. So that's another approach.
I mean, I actually work closely with a GIN endocrinologist, a very thoughtful guy, and I think a number of these patients have significant hormonal issues, gynecological issues, and so on. And having that kind of an expertise available, of course, recognizing them and then sending them, and he does a whole array of testing on them, and then he defines if, first of all, do they have a problem? And then if he identifies the problem, one of the nice things he does is he compounds medications. What he emphasized to me, which actually literally opened my eyes, is if you go for the standard estrogen, progesterone, standard hormone pills, they all come in very fixed doses. But he said that doesn't work for majority of these people, because you need very fine tuning of these hormones, and it's much more fine tuning than you'd ever want to do it, because each body is very different. And so he literally has them compounded for each patient. And that kind of fine tuning really has a major impact. And this co-management is what both of you are saying, I think can really be very helpful in whether we have a psychologist colleague, whether we have a gynecologist colleague, urologist colleague, or some, or as colleagues bring a multidisciplinary team approach, including perhaps nutritionists, they can be very, very helpful. So thank you for those thoughts. And so I think I'd like to wrap up our discussion here, and I want each of you to share some thoughts as a message. If someone listening to us or watching this, let me ask you, Andrea, first, if it's a peer or a physician listening to this, what would be a quick message that you would give them on the topic of IBS?
I would, from just a very basic perspective, I think with IBS, we have so many different options, not only in the pharmacologic category, but in terms of, if we want to integrate other types of therapies as well. And trying to, like Ali said, in those visits, really trying to understand the patient and what their goals are and what sorts of treatments they want to implement early on, because there are so many options, and using where resources are available, trying to use multiple or multimodal therapies when we can, and kind of tailoring your treatment plan depending on not only just the patient's symptoms, but what they have the most interest in. Are they interested in early integration of brain-gut behavioral therapies? Do they want more dietary counseling beyond what they've done, or do they want to, opt for the pharmacotherapies? It doesn't have to always go in one, sequence. Right. And so taking the time to understand what their goals are, and they're more likely to respond to treatments that they're interested in.
Okay. You've actually covered both the physician and patient perspective wonderfully. So then, Ali, I was going to say, let's say there is a young fellow or a trainee listening to this podcast. So what kind of a message do you want to give him for the field and so on? And
Absolutely. So one thing that is very exciting and interesting about motility, my opinion, is that, yes, we have multiple treatments as well, but we have multiple tests, right? And a lot of these tests actually are very physiologic. Now, for example, there is electrogastrograms, body surface mapping, right? So we have anorectal manometries, we have MR difficographies, we have small bowel follow-throughs, we have tests that can assess transit, we have breath testing. So it's very important to understand how these tests work and get the history, set up a pre-test probability, it doesn't have to be exact, in your mind, and see that which test potentially can help these patients. For example, if patient has potential very obvious postprandial bloating with very specific food, I was like, okay, I need to do breath testing to see what's going on here, right? Or if patient has severe pelvic floor dysfunction or like dyspareunia, and some urinary symptoms, I was like, okay, I got to do some difficography to see what's going on. So you have to individualize diagnostic testing as well. That actually makes it very fun to manage these patients.
Wonderful. What a lovely discussion we had. So as a quick sum up, IBS is a very common problem which we all recognize. I think there are millions out there. But the good news I'm hearing from both of you is we have good tests to identify IBS or some overlapping conditions. We have good tools now to recognize some of the comorbidity issues. We have a very healthy discussion about the various treatment options, both initial treatment options and prescription treatment options. And really what I learned from both of you is really thinking about this as a multidisciplinary treatment program for many patients, especially those who are very refractory, and to personalize the treatment program because no one treatment will fit everybody. So we're really adapting that. And really, there is a lot of hope for our patients, for physician colleagues, and also for young trainees that this field has a lot of opportunities for research, for training, for treatment, and hopefully they'll embrace this. So with that, I'd like to thank both of you and thank you very much. And I hope you enjoy this podcast.
Thank you.
Thank you.